This video examines the pitfalls medical students face when they first start taking history and examining patients that I've observed over a number of years. This is a picture of Ronald Reagan, American president. He's just made a speech, he's waving to the crowd and walking back to the car. What happened next may well have changed the course of history and how he was treated in the hospital. I'll come back to this later in the video. All medical schools publish the way they would want the medical students to take history and examine patients, and it's important that medical students learn the sequence, perhaps make their own notes that are easier to remember and carry in their pockets. The history taking and examination skill booklet may look something like this. The objective of this exercise, i.e. the history taking and examining patients, is to arrive at a diagnosis so that treatment can begin. It also establishes a bond with the patient, and if done appropriately, patients find solace just from being listened to and examined in a caring manner. Okay, so let's look at history and what can go wrong there. Presenting complaint. I often see students presenting with this, which is a headline banner, and it really should just be the one problem that's brought patient to the hospital, but sometimes students will present multiple presenting complaints, which is not appropriate, and then missing the duration of the symptoms. Chest pain, 6 hours, that is enough for this purpose. Now, history of the presenting complaint. It is important that when symptoms arise that students go back to when the patient was well and then follow each of its symptoms through and see how it has evolved. For instance, if someone presented with epigastric pain that then radiated to the right iliac fossa and changed in character and it was more severe, then we just need to follow it through, because that will tell you exactly how the issue is evolving. Typically, students would fixate on the first symptom but forget about the rest, or do not pay the other symptoms as much important. Each symptom, such as pain, vomiting, diarrhea, whatever else there is, abdominal distension, constipation, each of these symptoms need to be examined in its own right if that is what the patient has got. Now, this is different to the systemic inquiry that you are supposed to conduct a bit later on, but if a symptom has been presented to you and is part of the initial issue, then you ought to take a full history. Experienced clinicians would look for patterns, and they would look for a fit towards one diagnosis. There usually is one unifying diagnosis for a variety of presentation, and once students become more experienced, they would start to recognize this. Medication history is often problematic. There is missing dose, and often the patients themselves are a bit confused about allergy, which is an anaphylactic reaction, versus intolerance, which is inability to cope with the side effects. Equally, the patient's memory can be hazy, and they may not quite recollect what exact allergic reaction they suffered with the drug. It is important to get it right, because if we label a patient as allergic to a medication, we've taken out perhaps an important group of treatment or medication that is no longer available to the patient. Patients may not remember that they take over-the-counter homeopathic, recreational or herbal medication, or may not volunteer this information readily. Estrogen-based products that the patient take may not be volunteered in terms of information, and sometimes this goes missing. Gynecological history is often missing if the female does not have direct gynecological issues. Now, examination skills, I'll start by making some general points. Medical students tend to come from fairly hardworking academic backgrounds, and the tendency is to sit and read the book or to read alone and learn, and that is all good for most purposes, but for history-taking examination skills, specifically examination skills, it is really important that the medical students actually go out and practice. Then there are those who do go out to the hospitals and to the clinics, but do not learn the actual examination skills. They may see patients, but not in a way, and do not learn the skill the way it's meant to, and that is problematic. Because what happens is that if you learn something the night before, you're focused as a student too much in the exam on getting the sequence right. And while you're trying to remember what you're supposed to be doing next, you're going to miss important signs that the patient is supposedly presented with or is talking to you about. And that is a common issue. Equally, it's incumbent on the medical students to expand their knowledge base, because what the mind doesn't know, the eye is not going to pick it up. There shouldn't be any reason not to examine the patient thoroughly, and any cause offered is not good enough. It is okay to be somewhat nervous to start with, but pretty much all students then get in their stride as they get more experience. Now here are some key issues. Failure to get the patient in the right position to examine, failure to expose the part that you're meant to examine, and then failure to examine altogether. Now these are some of the key issues that I've seen. Now IPPA is inspection, palpation, percussion, auscultation. This applies to every area that the medical student examines, and this sequence must be remembered and must be used as a mnemonic when faced with unfamiliar circumstances, and it is unlikely that they're going to miss much if they follow this pattern. Now, when describing signs, medical students often come back with statements such as maybe there was tenderness, I'm not sure, maybe there was rigidity. So a sign is something that you elicit, and a symptom is something that the patient tells you about. Now, a sign is either present or not present, and if you insert too many maybes about a sign, then that information cannot be used to make a diagnosis. And it is understandable to start with that as medical students will face some issues there, but as you progress in your career, it's really important to believe what you are doing and what you've just examined. Okay, moving to the general examination, just knowing the sequence, starting from the hand and then moving up towards the head and then moving down again. Almost every student talks about clubbing, koilonychia and splinter hemorrhages. I doubt if they were presented with these findings that they would actually recognize it. So if you're going to say something in an examination situation, it's really important that you actually know and understand what that condition looks like and what it's associated with. Missing to check for peripheral edema. So if patient is recumbent, then you'll be looking at sacral edema, and if they have been ambulant, then you'll look for ankle or pretibial edema. Now, lymphadenopathy is often missed, and there are only just a few areas on the surface of the body where lymph nodes may be examined. I'll just draw you a quick diagram here. In terms of the lymph nodal exam, let's just assume that this is a cartoon. This is the head, neck, this is the clavicle, this is the right arm, the left arm, this is the inguinal ligament. So lymph nodes on the surface are only palpable in a few areas within the head and neck itself. Let's just draw the carotid nodes over here, and there are several other areas where nodes may appear, the supraclavicular, and then moving on to the axilla or the armpit, and finally the groin, where these lymph nodes may be palpable. Medical students often ignore the assessment of lymph nodes in the general examination. The abdominal examination, so the quintessential exposure is absolutely essential. And when inspecting, you should observe and don't just say what you've learnt, such as umbilicus is this and so on, and the abdomen is flat, unless it truly is. And often the scars on the abdomen of previous operations are not talked about. When palpating, especially if patients have got abdominal pain, students would often not look at the face to pick up the first grimace or sign of pain, and that is problematic because they can then go on and cause pain, which sometimes in an exam situation may not bode well for them. The rebound tenderness, generations of doctors have been taught to stick their hand into that belly and then to take it out suddenly. This would cause pain in anyone, whether they have disease or not. This is barbaric and ought to be stopped and replaced by percussion tenderness. Must check for cough impulse, especially if there is an incision or when examining the groin. Now, percussion, medical students often do not know how to percuss. This is something that they can easily practice at home. All you need is to hit the middle failings of your non-dominant hand with the middle finger, tip of the middle finger, using the wrist, and then see what sound is produced. And the whole point is to know whether there is fluid underneath, whether it's something more firm, or whether it's gas, and each would produce a different note. So it's surprising that students just are unable to practice this and come back with something that they might just do credibly in a fashion that will give them an answer. And of course, if there's fluid in the abdomen, then you should know about fluid shifts and how to examine that. Auscultation is, again, they're quite weak, especially for bowel sounds, and all you need to do is to put the stethoscope to your own abdomen to know what that sounds like, and what would it sound like if there were no bowel sounds, and what would it sound like if there were tinkling, such as in ileus, or what if they were high pitched, such as in obstruction. Very few students, when asked to examine the abdomen, would actually even talk about examining the groin, and hence they may, as doctors miss, torsion of the testes, strangulated hernia, or femoral aneurysms. Digital rectal examination is appropriate in the right context. You would need the consent of the patient, you would need a chaperone, and so on. However, for most practical purposes, I think it's best to practice this on a dummy and to get your skills right when you need them. Respiratory assessment follows the same pattern. Exposure is often an issue. Percussion is not great, and you can easily differentiate between a pneumothorax, pleural effusion, a pneumonic patch just by percussing. And often medical students would not know what to do with the stethoscope other than to say, talk about whether there was good air entry or not, and not know about the breath sounds, which are vesicular, which are normal, and then added sounds such as bronchial, crepitation, and rhonchi, and to know the significance of each. And it's important that these are learnt along the course in medical school. Cardiovascular system, again, not being able to pick up arrhythmias or getting the position right, the 45 degrees tilt for assessing the jugular-venous pulse, or differentiating the JVP from the carotid pulsation. And then not knowing about the first and second heart sound or murmurs, picking up murmurs. Students often find the central nervous system difficult to examine, but actually it's all about the circuitry. With the central nervous system, if the circuit is broken, then the sign which presents itself as a bulb just goes off. And so if you know the pathway and innervation of the, say, cranial nerves or of the motor nerves, or the lower motor neurons and upper motor neurons, and so on, if you know the circuitry, it's very, very easy to work out. So the anatomy bit of it comes before you start examining the central nervous system to make sense of this, and then it will be very straightforward. So we are now towards the home stretch. Our students often do not pay enough attention to the patient's perception, understanding, and expectation. Often when asked for a differential diagnosis, they will come up with rare diagnoses. So common things are common. 1 or 2 diagnoses should explain the situation, and keep the rare things to the last. Certainly if you say something rare as a rare diagnosis, your next question will be about that. You should have some understanding of the investigations required, and then finally the treatment. So coming back to this picture, yes, Ronald Reagan was walking back, and just from this point onwards he took 2 more steps, and there was a gunman standing and he fired 6 shots at the president. He missed all 6, but the last bullet ricocheted off the limousine, which was bulletproof, and hit the president. The president did not know that he had been hit. His staff did not know that he had been hit by the bullet, and they bundled him in the car and started driving. It was only the presence of mind of his staff who took him to the hospital. And in the hospital, when he arrived, he was a bit upset. He didn't want to go to the hospital. They cut his suit off very quickly. There was a very trained trauma team there, and they realized that he was hypotensive and tachycardic. And when they cut the suit, they found a bullet hole. He was stabilized and then needed thoracotomy. They opened the chest to stop the bleeding. Hence, just the sequence of taking a history examination and so on saved the day for a very trained team who were present there. They saved this man's life. So summing up, I've just illustrated how important it is to have your own system of history taking examination. This is something that's going to stay with you for the rest of your life, and if you do it well, you're not going to forget and you're not going to miss important findings. I can't say enough about practicing your skills. You have to embrace this unique privilege that the patients have given you to examine them, knowing fully well that as students you're unable to help them, but they wish to contribute to your knowledge, they wish to contribute to your experience. So never abuse that. And it is okay to be compassionate. It is okay to place a hand on the patient's hand and to reassure them. They will not think ill of you, and they will not question your motive. So don't worry about that. You should be attentive in history taking and ruthless when examining. I do not mean ruthless in a bad sense, but again, exposing the patient, getting them in the right position, and being thorough in your examination. That is the least that the patient deserves. And finally, trust your game. So once you start gaining experience, you should be able to trust what the history you've taken and the signs you've elicited and what that has led you towards, irrespective of whether or not a more senior person or a more senior doctor has come to a different conclusion. You should examine and believe what you've just done, and then compare and see where you can learn. I hope this has been of some use. Please do leave some comments if there are any other points that I've missed or that might be helpful. Thank you very much.